With this said, though, let me take the scenario the other way around. And you remember, we were talking about atezolizumab. Now the patient come with atezolizumab. They do great. We can manage it. We looked at the endoscopies. We managed everything as needed. But ultimately, the patient progress. So now the question go back. You have a patient, Anthony, on atezolizumab. They need second-line therapy. What are you going to do?
So this is a challenging area, right, with no data at this point. And I think the best way to describe it, I think there are two schools of thought. One school of thought is to say, okay, we started with atezolizumab, and then we reset the clock from there. So that's like line -1, and then we start. This is something you said exactly.
Yeah, of course. By the way, I tweet quite a bit about HCC at G Abou-Alfa, Gabou-Alfa. That's kind of marketing for my Twitter as well.
So as you said, line -1, then you would reset the clock and start with lenvatinib or sorafenib and continue from there with sequencing of the agents. Versus another school of thought that says, well, let's go from atezolizumab to the second or third line agents that have been tested already, such as cabo, rego, and ramucirumab. Certainly, as I alluded to earlier, it would not make sense post-atezolizumab to use the anti-PD-1 agents as single agents in second line.
Fair enough, and this is very intriguing. And those two schools of thoughts. So, Ahmed, which school are you from?
Yeah, so definitely I would not challenge a patient who progressed on checkpoint inhibitor plus anti-VEGF with a checkpoint inhibitor alone. But I totally agree with the other targeted therapies are different. They have different mechanisms of action. So whoever progresses on bevacizumab, I think it is still okay to go to a tyrosine kinase inhibitor, multi-targeted therapy. So there is a room for that. And by the way, this is not peculiar to HCC. We've been through that road before in many, many other cancers where everything gets revamped again, as long as you're using something with a different mechanism of action.
Let me go back to what Anthony is mentioning. So atezolizumab first line, I agree with you. We're not going to go ahead and challenge again with the checkpoint inhibitors, and this is yet to be discovered with data. But my question is, are we kind of going backward and let's say go sorafenib, or are we jumping to cabozantinib as second line?
Yeah, so in my practice, I usually personalize the approach. So there is some data from meta-analysis of multiple large phase 3 studies for sorafenib that showed a trend towards better benefit in Hep C. So in Hep C, I usually use sorafenib. Hep B, there is a trend towards better lenvatinib frontline, cabozantinib as well. So you kind of personalize your approach also in a way based on risk factors and demographics. I think the major transformation is going to happen when we have other combinations approved. So pembrolizumab, for example. So here you have checkpoint inhibitor plus TKI. So would you do that after atezolizumab? So this is going to be even more interesting to see.
Fair enough. Peter, patient get atezolizumab, okay? And again, I like very much the way Anthony described it. Do you go back to lenvatinib, sorafenib, or would you jump to second line cabozantinib?
Yeah, I've been thinking about this quite a bit, again, in the absence of data. And I would consider going back to first-line therapy options and amnesia strategy. You basically convince yourself that nothing happened in the past however many months, and you reset the clock and start frontline therapy again. I am not a medical oncologist. This is probably a good disclaimer to offer at this point. But in my mind, it makes more sense to use established second-line treatments. Those would be cabozantinib and certainly regorafenib in the appropriate setting, as opposed to resetting the clock and using first-line therapy.
Fair enough. And I can definitely see the two lines.